respected MD, my senior colleagues and professionals. Today I am presenting a case which all clinicians encounter in their lifetime, day in and day out. That is about a female patient who is now admitted to ICU, bed number 7, Mrs. Rama Chatterjee, 86-year female, from Kolkata Metro Street, the wife of a retired employee, S.N. Chatterjee, ex-section officer, accounts, JRC. So she was admitted on 23rd of October with history of altered sensorium, drowsiness, disorientation of 2 days duration on 23rd night at 10:30 p.m. with a history of near syncope on 21st of October. But there is no loss of consciousness, no history of head injury. Along with it, there was history of incontinence of urine preceding to it around of 2 weeks duration, and the patient was bedridden, means bed bound, only restricted physical activity, otherwise bed bound for last 2 months, and there was past history of diabetes mellitus of 12 years duration on human mixed insulin 20 units before breakfast and 6 units before dinner, and she was taking treatment from outside, and there was history of declining cognitive function for last 6 months. So regarding the present history of present illness, she presented altered sensorium, drowsiness and disorientation of 2 days duration on 23rd night with a history of near syncope on 21st. No loss of consciousness, no head injury, no convulsion, but she was having bodily restless movement of all 4 limbs. All the time all the 4 limbs are restless, and with a past history of diabetes mellitus and incontinence of urine, impaired cognitive function for 6 months, but diabetes mellitus for 12 years with on insulin. So on examination at the time of admission, her blood pressure was 150 by 80 mm mercury, and pulse rate was 54 per minute, fairly regular. Respiration 26 per minute. There was no edema. Anemia was of mild degree. There is no enlarged cervical lymphadenopathy. Temperature was normal. No cyanosis, no globin. But on the next day, I am telling the sequential event. On the next day, her blood pressure came down to 90 by 60 on 24th morning. So she was put on pressure amines for around 24 hours. And after that, her blood pressure is maintained all along till date. Currently, her blood pressure is going around 120 by 70 or 110 by 70. And her lungs examination, respiration rate was 26 per minute, and it was thoracoabdominal. There was no paradoxical respiration. Trachea central, resonant on either side. Breath sound vesicular with crepitation on right infrascapular and interscapular area on the right side only. There was no pleural lobe. CBS examination, heart sound, first, second sound normal, no murmur, no pericardial lobe. Peritoneal examination, liver was not enlarged, spleen not palpable, kidney not palatable, no ascites, and peristalsis sounds are normal. CNS examination, patient was conscious, confused, and disoriented, markedly disoriented, and she was having bedwetting, and she was having involuntary movements all along up to around 28th of October, from 23rd to 28th, and she was moving all 4 limbs. There are no meningeal signs. So with these clinical findings, initial diagnosis was, and the plantar was extensor, though meningeal signs are not there. Plantar was extensor, but she was moving all 4 limbs. So the clinical diagnosis was a case of diabetes mellitus, dementia, possibly because she has declining cognitive function, bedridden for certain long period of time, and So diabetes mellitus, dementia, sepsis, because pneumonia because of there is crepitation on the right side of the lung, so there is possibility of pneumonia, and there is a plantar was extensor and patient was extremely restless. So possible explanation for the extensor plantar, again the patients are moving all four limbs. Could it be a possible association of electrolyte imbalance because she was elderly, diabetic, and with all these things, could it be a case of combination with dyselectrolytemia? Because hyponatremia will cause cerebral edema, and there will be plantar will be extensor on either side, although the patient are moving all four limbs. So my clinical diagnosis for the case of diabetes mellitus, dementia, pneumonia, sepsis, dyselectrolytemia. So with this background, we proceeded for the investigation. Immediately CBG was done, capillary blood glucose was done. Capillary blood glucose was 41 at the time of admission. So she was conventional and she was put on 25% glucose, 200 ml, followed by a run of 5% glucose. And the biochemical reports, which I will be reading on different dates, I will be reading now. The biochemical reports, this sand on that time on receiving blood 25% glucose, the RBS revealed 278, urea was 92, creatinine 2.4, that is on 23rd. Sodium was 114, 114, and potassium was 7.7. On the same day, ECG was taken at the same time. ECG revealed, if you have time, you can see the ECG, various ECG.
I am giving you, and simultaneously I will.
ECG on day of admission, it was junction on rhythm on 23rd ECG, junction on rhythm with tall T wave and with a heart rate of 55 per minute. I explained in my clinic examination, the heart rate was around 55, so it was a bradycardia. There is no P wave, junction on rhythm means there is no P wave, and there is tall T. So which is clinically with biochemical reports, it is going in favor, it is the junction on rhythm and potassium was high. And sodium was 114, so patient was having altered sensorium, there was plantar was extension. And the leukocyte count on that day was 7,200, but subsequently on 25th, leukocyte count went up to 13,300. 13, 1 on 25th, but on 23rd it was 7,200. And hemoglobin was 8.4, platelet was 2.2 lakh. Coming to other biochemical reports on subsequent times, or I can go by ECG, different date. On ECG on 24th, it was sinus rhythm. After putting on 3% of sodium chloride and 5% of glucose, and 25% glucose with insulin and aspirin nebulization. ECG on the next day was revealed sinus rhythm around 100 per minute. ECG there, and ST depression was there with a little bit of white TY response. And ECG on 25th, there was sinus rhythm. PR was 0.22 second, means it was PR was interval was prolonged, and there was white QRS complex and tall T. There are some features of hyperkalemia. The PR prolongation is also hyperkalemia. White QRS is prolongation, so hyperkalemia, tall T. Then on 26th, another ECG was taken. P was absent, and it was regular, of course, and white QRS complex. and duration of 0.16, almost covering 4 small square, means big square means 5 on it is covering 4 to 0.16 second, and subsequently on 28 ECG sinus rhythm and normal. On different dates I am clinically going by the potassium on 24th 6.8 and 25th 8 milliequivalent. On 26th again pre-dialysis, because we have to seeing all the GCG finding and the potassium was not coming up despite of calcium gluconate, 25% glucose with insulin and asthal nebulization, it was not coming up, it was coming down, and creatinine was going up. Creatinine from day of admission it was 2.4, on 24 4.8, again 23 5.6, 26 5. So it was gradually increasing, and potassium was also rising, and there are bodily restless movement. So if despite of all these three measures, potassium was not coming down. So on 26th, with all these ECG, with a lot of agitation, dialysis was initiated, because with this ECG, there was at any patient, at any time, patient could have gone to assistol and could have died. And explaining the party that there is no other option, we have to try. Then with a lot of dialysis was done, and post dialysis potassium came down to 7.5 from 8.6. Post dialysis same day to 7.5. Again on 27 it was 7.5. Again on 28 because of 7.5. Again 28 another dialysis was done. Pre dialysis was 7.5, and post dialysis it came out to be 5.4. And after that 5.7, 5.4.8, this is the sequence. Last report of 38 is 4.8. And sodium on different dates, sodium 114 on admission, then gradually went up. Pre-dialysis was 122, then after dialysis 127, now it is around 130. So electrolyte imbalance has been corrected gradually, and creatinine is coming down. Now creatinine is 3.2, latest from 38, and urea is 82. It went up to 134 on pre-dialysis, means on 26, and then on 30th it has come down to 82. And patient sensorium has improved since yesterday. Since on yesterday she was able to recognize. Now GCS is 50. Body restless movement has come down. She is quite comfortable. She is now taking oral. Good morning, sir. We are discussing a clinical case of sepsis, and the patient was a case of 86 years lady, diabetic, on insulin, came with altered sensorium, disorientation, and syncope, near syncope, with bedridden for last 2 months, and declining cognitive. He came with electrolyte imbalance, hypoglycemia, and all those things. So other investigations like CKMB is 19, LDH is 150, and liver function, albumin was 2.4 gram, and SGOT-PT normal, alkaline phosphate is normal. So then urine examination revealed plenty of pustules, urine exam, and culture revealed E. coli sensitive to 5% azorectum and amicus. Along with it, she was taken ECG, X-ray on day of admission. There is bronchopneumonia, there is homogeneous opacity on the right paratracheal and right paracardial. So there is bronchopneumonia. That
इजी चेस्ट एक्सरे लेके आइए ना सबको
ये स्कैन करके निकाल
Pass it on. Good job.
X-ray. So X-ray on 23rd, that is bronchopneumonia on the right side, and X-ray done yesterday. That pneumonia has resolved. That pneumonia has resolved, and sensory of the patient is developed. Now she is taking over. And only on day 2 means 24, she was put on pressure. On 26, dialysis first. On 28, second sitting of dialysis with antibiotics, correction of sodium by 3%, not 3% NaCl, and potassium reducing agents like calcium gluconate, membrane stabilizing calcium gluconate. If calcium gluconate is continued till 28, and 25% glucose with insulin and nebulization. It was continued from 23rd to 28. And now the patient is sitting, is talking, she is recognizing persons, although she was having features of dementia. And the rest of the things, treatment part, I have narrated what is the treatment rendered. Now, sputum examination, because patient was not in a position to bring out sputum, and the X-ray is showing this. So for potassium, she was initially given with calcium gluconate 25%. Almost she was given 6 hours from 23rd to 28. Then 25% glucose with insulin 8 units, 8 hours. Nebulization, nasal nebulization 6 hours plus dialysis for hyperkalemia. So she was treated for hyperkalemia. She was treated for sepsis with 5% tazobactam, of course in a dose of 2.25 only. And then because of the bodily restlessness, because I was not able to put on the sedatives, I put her because of the involuntary movements. I thought possibly convulsion because of hypertension. I put initially with Encoret injection, but I withdrew it on 28 after seeing that the movements has come down. And because the potassium was not coming up, and that was the reason for body movement, muscle movement, because muscle contains around 90% of the total body potassium. That muscle movement was restricting to come down, bring down the potassium. So she was put on dialysis, 2 sittings have been done, and she has got nicely improved. So these are the patient having a multi-organ dysfunction, elderly lady of 86 with comorbid condition, with meticulous treatment can come up. Of course, we know that more than 50% of the patients and elderly, of course, they die with sepsis. Of course, this lady had multi-organ dysfunction with comorbid condition, has survived. So, with this background, I will be discussing some of the effects of the severe sepsis and septic shock, which I will quickly cover.
In this case, the primary was chest infection or urinary infection?
That
Or simultaneously?